Hello everyone. Welcome to this edition of pathCast. I am Rifat Manan from Baltimore and I am joined by my colleague Dr. Emilio Madrigal from Atlanta. Today we are pleased to host a slide seminar by Dr. Kyoko Oshima from Johns Hopkins Hospital. She is going to present about liver transplant pathology over the next 1 hour. As always, please feel free to have your questions as comments on Facebook Live or YouTube, and we will be happy to pass them over to Dr. Oshima and she will answer them at the end of the session. With this, I will hand over the microphone to Dr. Oshima now. Thank you, Dr. Oshima.
So let me start from recipient. So who needs liver transplant? So there are two major different groups. So one is obviously cirrhotic patient, like chronic disease patient. The other group is acute liver failure patient. So now you can see on the screen, so this is an example of acute liver failure we got last month. So you can see extensive necrosis. You don't see any normal hepatocytes here. And here you can see residual hepatocytes. Actually, this case, so radiology, it looked like cirrhotic liver because of residual, this hepatic parenchyma look like nodule. And for clinicians, so acute or chronic, that makes a huge difference. If the patient has cirrhosis, emergency transplant is not indicated. However, the acute liver failure, so emergency transplant is indicated. In this country, if the patient is listed as emergency transplant patient, so they can get top priority on the, for example, in Baltimore, on the East Coast. So whenever next donor is available, the patient can get this liver. However, for clinicians, it's a huge decision. The reason is that, of course, the patient can survive without transplant. It's much better once you receive transplant, so you have to take immunosuppressor through the life. So the clinician must make a huge decision, transplant should be offered, yes or no. At that time, the most important information is whether this is cirrhosis or truly acute liver failure. And also timing is difficult, so we never know when next donor will become available. So once you miss one, so you never know when the next one is coming. So could be in 1 hour, could be 1 week. So it's a huge pressure for clinicians. For example, like this slide, so you don't, this is trichrome. You can see residual hepatocytes, but there is no fibrosis at all. And sometimes PA stain can be helpful, so PA stain, we usually don't do it. But very small amount of hepatocytes is stained with PAS. Normally, PAS stain glycogen, so PAS stain hepatocytes everywhere. So hepatocytes should be all red in PAS, but like this liver failure case, so you can see very small amount of viable hepatocytes, which is highlighted nicely, and we can estimate how much hepatocytes are viable. Also, reticulin stain are helpful. So normally, hepatocytes, you can see 1 to 2 cell thickness hepatic cord. So here is normal hepatocytes. On the other hand, area of necrosis, so atrophic cord. So this is collapse, but still you can see some by some residual hepatocytes. So this is not fibrosis. So all hepatocytes necrosis. Actually, this case, before 2 weeks before liver transplant, liver biopsy was performed at private practice, like community hospital. So even general pathologists, you may have to deal with acute liver failure patient. And when you read liver biopsy, so what you should report, the most important thing is fibrosis. How much fibrosis is there? And actually, this case, 2 weeks ago, hepatocyte necrosis were not so much. Here in the center, you can see some mild hepatocyte necrosis. However, there was not extensive necrosis. However, another thing you should pay attention is to look for plasma cells. So, like this case, acute liver failure, the most common cause is drugs. In this country, acetaminophen toxicity is the #1 cause. However, drug and infection is possible. For example, hepatitis A, B, C never happen, hardly happen acute liver failure, but also herpes, A, B, herpes could cause acute liver failure. And actually, this patient, hepatitis A is positive. So possible hepatitis A related acute liver failure. And another pitfall is, so when this patient received this liver biopsy, ALT, AST were about 1,000. However, after that, the patient's ALT started to decline. And when the patient was transferred to our institution, so ALT, AST were several hundred levels, it has been declined. But acute liver failure patient decreasing ALT, AST does not mean the patient is getting better. Sometimes it's worsening because of liver enzyme is totally exhausted. And then ALT, AST becomes lower. In this case, ALT, AST was declining, and the clinician was wondering whether the patient was getting better or getting worse. But the decision was made, and the liver transplant was performed, and it was correct decision because extensive necrosis. So without liver transplant, there was no way for this patient to survive this case. And for example, this is trichrome stain. So staining is not so optimal, but due to edema, you may see some sky blue staining, but please don't read as fibrosis. So you can expect sky blue stain. These are not true fibrosis. So you have to read only these dark stains. So this is no significant fibrosis. So this is example of acute liver failure. And how about cirrhosis patient? And the most common cirrhosis in this country is still hepatitis C. However, last 4 or 5 years, direct antiviral agents, so hepatitis C nowadays become curable disease. It has changed our practice drastically. So I'm sure hepatitis C transplant will be declining shortly, but still hepatitis C is #1 cirrhotic patient in this country. And once it becomes cirrhosis, it is very difficult to identify etiology because all diseases looks very similar. But hepatitis C, so you can see lymphoid aggregates, and you can see round nodules. So hepatitis C nodules tend to be round, and actually what is this? So this is foreign body material. So hepatitis C patient is often associated with hepatocellular carcinoma. And this was TACE, transarterial chemoembolization. So the patient is often treated with embolization for hepatocellular carcinoma. So this is emboli related to treatment. So this patient have a hepatocellular carcinoma in explant. And in North America, so there is Milan criteria. So cirrhotic patient with early stage of hepatocellular carcinoma can get higher priority to receive liver transplant. Sometimes it's not fair because the patient having cirrhosis without cancer have to wait longer time, and this patient also could die from liver failure. But Milan criteria, so if the HCC is up to is only one up to 5 centimeter, and if it's multiple, must be up to 3, and the greatest measurement needs to be less than 3 centimeter. And of course, the patients are waiting for transplant for a file. So 6 months, 1 year, so have to wait. So for a mean file, so this patient often receive embolization. And so this is embolized hepatocellular carcinoma. You can see necrotic area, so embolized material. And here is residual hepatocellular carcinoma. So as pseudoacinar formation, and NC ratio is increased, and so here you can see residual hepatocellular carcinoma. And another big population is alcohol. Actually, in this country, generally, 6 months to 1 year abstinence is requirement to receive transplant. So the patient may start drinking again. Generally, when people become cirrhotic, they are too sick and they stop drinking. They just physically cannot take alcohol anymore, but they may start to be drinking after they feel better. So because of that reason, so generally 6 months to 1 year abstinence is requirement in this country. However, our institution offer even acute alcoholic hepatitis patients, somebody drinking this month, so we offer transplant as well. So we are getting quite a few number of alcoholic patients. And actually this Mallory tank body, this is the worst Mallory tank body I've seen in my practice. So please look at this red material. So these are all Mallory tank bodies. So here you can see some balloon cells, so steatosis. And often acute severe steatohepatitis or cirrhosis, you don't see steatosis very much anymore. So here is some macrovascular steatosis. However, so this extensive degree of Mallory tank body. So this degree is highly indicative of alcohol-related steatohepatitis. So based upon histology, it's often difficult to distinguish between non-alcoholic NASH and alcoholic steatohepatitis. But this degree of Mallory tank body or extensive neutrophil and also fibrosis pattern are different. For extensive sinusoidal fibrosis like this, it's highly indicative of alcohol. And for example, this is acute alcoholic case, so you really don't see nice nodules, so highly fibrosis is characteristic and sinusoidal fibrosis pattern. On the other hand, somebody who stopped drinking long time back, and this is example. So often it becomes micronodular cirrhosis, and actually, so I have to scrutinize. I marked here because I found Mallory tank body here. So fat will become is gone, and Mallory tank body is gone, and So it's very difficult to say this is alcoholic-related liver injury. But this is example of chronic alcohol liver injury, and trichromostain shows nice micronodular cirrhosis like this. Also, but difficulty of liver pathology. This case is also alcoholic patient. However, PASD shows nice alpha-1 antitrypsin globus. So liver pathology, even if you find one name, you shouldn't be satisfied yet. So the same patient may have two different diseases. So PASD, so this patient had alcohol-related liver injury as well as alpha-1 antitrypsin deficiency. Generally, only homozygote patient becomes symptomatic, but in alcoholic patients, so already chronic liver disease is there, so even heterozygote alpha-1 antitrypsin disease patient becomes this kind of symptomatic like this. And how about biliary cirrhosis? So for example, this is example of cholestatic cirrhosis. As I said, once cirrhosis is developed, it's very difficult to determine etiology. However, at least we should try to distinguish between hepatic or cholestatic. This is example of cholestatic cirrhosis. So nodule is very irregular, and we call jigsaw puzzle pattern. So this is irregular, and also please look at the edge of the nodule so you can see pale area. It's called cholestatic halo, and it is highly indicative of cholestatic disease. Actually, this patient has PBC, and PBC patients tend to have ductopenia. So look around, and if there is no bile duct, particularly small bile duct is specifically affected in PBC patient. So you don't see any good bile duct here. So that's why we can tell this is most likely cholestatic cirrhosis. And this case is primary sclerosing cholangitis. So PSC in liver as a result, as a rule, so artery and bile duct, they must be together most of the time. And here is artery, and there should be bile duct. So it's completely obstructed by fibrous. So fibrous obliteration. This is example of primary sclerosing cholangitis. And so these are recipients in adult chronic liver disease. And how about pediatric recipients? So number one cause for pediatric is biliary atresia. So biliary atresia, so you can see obstruction of common bile duct. So this is resection specimen when Kasai procedure was performed. So here you can see very narrow lumen, and this is focal. And for example, this is narrow. However, same patient, other area, common bile duct here, like patent. And how about liver? So liver, in hepatic parenchyma, you can see some bile ductular reaction. And also, you can often see bile plaque in bile duct, which is very helpful for to confirm diagnosis of biliary atresia. However, so differential diagnosis. how about this area? So you can see extensive bile ductular reaction around. And also, you can see some giant cells often in biliary atresia. So differential diagnosis would becomes like neonatal giant hepatitis, or also alpha-1 antitrypsin globulus also is differential. So you must do a PASD. However, less than 12 weeks infant, alpha-1 antitrypsin is not well formed, so it could be teeny tiny. So, and other, so these are differential diagnosis for pediatric person. And the Kasai procedure should be done at the beginning of 2 months. And however, it often fails later on, and eventually the patient needs transplant when they grow up later. And how about donor? And as I said, in the North America, greater than 95% are cadaveric donor. So only pathologists, we have to come in for the frozen section 2 or 3 o'clock. That's the common scenario for us for liver transplant donor evaluation. Because donor becomes available, so we really don't know past medical history. So if frozen sections are requested by surgeons, so we have to come in even 2-3 o'clock in the morning, and partly because so-called ischemic time less than 12 hours is ideal, so they cannot wait until next day morning. So donor evaluation, of course, so we have to evaluate inflammation, degree of fibrosis, and also important thing is degree of steatosis. And steatosis often prevent endothelial cell reperfusion. So if there is more than 40% of steatosis, it's not a good liver, and they tend to have tough dysfunction early after transplantation. So therefore, we are often, the most common reason for donor frozen section is evaluation for steatosis. And actually, grossly, if fat is too much, so it looks yellow. So even surgeon may abort the liver. However, if it's questionable, they ask us to do frozen section diagnosis. So this is example of frozen section. And this is obviously a lot of fat. And we told greater than 60%, so this liver was not used for transplant. And this is permanent section of this liver. And when you read steatosis, please, size of fat droplet is important. So please use nucleus size of the liver, and any fat greater than this nucleus we call large droplet of macrovascular steatosis. So these large droplets greater than 40% is one cutoff. So if it's greater than 40%, often this liver would be discarded. However, like this small droplet, like small one less than nucleus size, so these don't affect much. So any human being going through critical phase, so they may get this small droplet of steatosis. So when you receive evaluation, so don't count this small droplet. So look for only large droplet. For example, this case is, we estimated 25 to 30%, and probably this liver was used. So steatosis often starts from zone 3, like central vein area. And if zone 3 is affected, so the liver is composed of zone 1, 2, 3. So one zone is about 33%. Like this case, so about zone 3 only is affected. So it's estimated about 33%. So if the steatosis is zonal, so it's much easier to estimate. And for example, this case is much more difficult. The reason is that so some of them are small and some of them are big. And we often have to read these things like 2, 3 o'clock in the morning. So got up from bed, so it's not the ideal time to look at something. And in sleepy eyes, so it could be challenging. And so ideal donor is young, probably died from trauma, and these are ideal donor. However, because of waiting list for liver transplant is long, so we are using extended criteria donors. So who are extended criteria donors? So age, for example, older than 60 years old, and like steatosis greater than 40%. And also I died from like a cardiovascular event. So these are not ideal candidate donor. However, we started to use this kind of donors. And also sometimes we split one liver and split half and transplant 2 patients. So that's also another factor to consider. So our pathologist role is whenever we have to evaluate donors, so degree of inflammation, so whether inflammation mild, moderate, severe. So look for fibrosis, or of course based upon HND, so it's difficult, but try our best and look for steatosis and necrosis. So generally necrosis, more than 10%, the liver will be discarded. And also fibrosis up to mild can be used. So liver don't, and oiled O could be used, but oiled O for evaluation for steatosis, so you need like frozen tissue. So this is oiled O stain, so it stains fat, small droplet with red, but it's not commonly used in this country. And after transplant, so liver function should get better within a couple of weeks. However, if liver functions does not recover well, so liver biopsy could be performed. And this is preservation injury, very common finding right after transplant. So after 2-3 weeks, it's common to see it. And this is one of the worst examples. So preservation injury, main finding is zone 3 hepatocytes necrosis. So here you can see healthy hepatocytes. So here is zone 3. So zone 3 hepatocytes are swollen. Here is central vein. And you can see cholestasis and some histiocytes. So this is typical for zone preservation injury. And for example, like this case, retransplant was needed, this case. So this is a drastic case. So here is central vein and zone 3, hepatocytes necrosis, degeneration, and cholestasis. And you can see histiocytes here. And this is preservation injury. And also, another vascular complication is arterial thrombosis. So this is arterial thrombosis can happen right after transplantation 1 month, within 1 month. So this is geographic necrosis, like here. And you can see blood flow. And this is coagulative necrosis. So here you don't see any nucleus at all. Coagulative necrosis. So example of hepatic artery thrombosis. And let's move on rejection. So acute cellular rejection, so which often happen within 1 year after transplant, but can happen anytime after 1 year. And this is T-cell mediated rejection. And Banff criteria is used. And Banff criteria, there is general assessment and RAI score, more detailed assessments. There are 2 different classifications. I usually use general assessment. So general assessment, but we grade mild, moderate, severe rejection. So this is typical example of moderate acute cellular rejection. So when you look at portal triad, so you can see inflammation everywhere. So acute cellular rejection, we have to evaluate 3 histologic findings. 1, portal inflammation. 2, endocellulitis, another name venulitis, and 3, bile duct injury. And mild rejection, so you can see histologic changes on the focal area. Moderate, you can see this inflammation everywhere, pretty much. And severe, you can see hepatocyte necrosis, or this more severe finding. So let's look at like this portal triad more detail. So here is endocellular hepatic vein and some lymphocytic infiltrate in endocellular cell, and bile duct injury and artery. Let's move to some another portal triad. How about this area? Oh, this area. So you can see nice T-cell mediated. So T-cell is specifically attacking endocellular cells. So you can see endocellular cell lifting up in hepatic vein. And here is also bile duct injury. And this case, you can see lymphocytes, eosinophil, and neutrophils. So when rejection is mild, you can see only lymphocytes. However, so rejection becomes moderate. So you started to see eosinophil, neutrophil, and this even blast. So here is bile duct injury here. So this is typical example of moderate acute cellular rejection. How about this area? So this portal triad. Here is nice bile duct injury. So bile duct epithelium is vacuolated, and you can see inflammatory cells. So endocellular cell injury and different type of inflammation. So this is moderate acute cellular rejection. For example, this is mild acute cellular rejection. So mild case, so inflammation, degree of inflammation is much milder, and endocellulitis or bile duct injury is very focal. And again, in portal triad, you can see lymphocytes only, so you don't see any eosinophil or neutrophil. However, some endocellulitis here, and here is very subtle mild bile duct injury, and the changes are focal. So this is example of mild acute cellular rejection. And difference of kidney and liver. For example, this case, Here you can see arteritis. But arteritis is extremely rare in liver. On the other hand, kidney transplant. So kidney transplant, arteritis is a requirement. Venulitis wouldn't be counted as rejection. So kidney, you must see arteritis. So in liver, you may see arteritis, but it's extremely rare. So we generally look for venulitis. And also, so delayed acute cellular rejection. Generally, right after transplant, within 6 months is early transplant with early T cell acute cellular rejection. And this type of rejection is like portal vein is dominant. On the other hand, after 6 months, so you may start to see some centrilobular endotheliitis. So this is some atypical type of acute cellular rejection. And how about chronic rejection? So chronic rejection. Often the patient with chronic rejection have episode of previous acute cellular rejection, but sometimes without an episode of acute cellular rejection, so chronic rejection can happen. And chronic rejection, so bile duct failure and loss of artery. For example, this is portal triad. Here is central vein, and this is portal triad. There is no bile duct. And here is possible artery, but it's so small. Let's look at another portal triad. This one, here is bile duct, but injured. Very atrophic, small bile duct, and artery is reduced. So this is good for chronic rejection. So there is Banff criteria. So by definition, to call bile duct penia, requirement is bile duct loss greater than 50%, which means that if there are 10 portal triads, so equal or more than 5, like half portal triad must lose bile duct, and then we can call bile duct penia. So early chronic rejection, so bile duct loss is less than 50%. So late chronic rejection, so bile duct loss is greater than 50%. And artery is 25% is cut off. So if there are 10 portal triads and 25 is 2.5, yeah. If only more than 3 portal triads lost artery, so it will be qualified for late arterial, late chronic rejection. And for example, CK7 could be helpful to do count. So because chronic rejection is a bad news, and because even increased immunosuppressor usually does not cure chronic rejection, and often the patient needs another transplant, which is bad news. So you may count exactly how many portal triad have how many interlobular bile duct. For example, this is portal triads, and you don't see any bile duct at all. And these hepatocytes are normally negative for CK7, but it becomes positive. So these hepatocytes are called intermediate hepatocytes. So hepatocytes gain biliary clarity. So it is indicative of cholestatic condition. If we can see aberrant expression of CK7 in hepatocytes, it's indicative of chronic cholestasis. And another finding for chronic rejection is zone 3 hepatocytes necrosis. So this is explant due to chronic rejection. So again, you don't see bile duct, and also similar to ischemic changes. So zone 3 hepatocytes necrosis can be seen. So bile duct loss, arterial loss, and zone 3 hepatocytes necrosis. And one more characteristic finding is hepatic artery, like forming histiocytes occlusion of hepatic artery. So here is artery from explant failed like chronic rejection. So here you can see artery. So these are forming degeneration. So artery's lumen is very narrow. And this is another case. So artery shows intimal thickening. However, problem is, so in liver biopsy, we hardly see large artery changes. So that's why we really cannot use it for diagnosis of chronic rejection in liver biopsy. But currently, BAM criteria, so there are 5 histologic findings, like bile duct loss, small arterial loss, and zone 3 hepatocytes necrosis, and forming arterial changes with luminal changes, and lastly, bile duct fibrosis. So if you can see 2 out of 5 histologic criteria, so chronic rejection diagnosis is established. But in reality, if we get liver biopsy, no way to see these big artery changes. So pretty much we have to decide chronic rejection diagnosis based upon small bile duct loss and small arterial loss. And also chronic rejection can happen without these histologic changes, and just start, it may show fibrosis like this. So irregular fibrosis. So that's why in BAM criteria, chronic rejection assessment, so you have to include fibrosis assessment like periportal, central vein, and sinusoidal. And if fibrosis is there, so without this bile duct loss, still this is one diagnostic criteria for chronic rejection. And I think this is time is almost over, so I would like to finish here. Can I, Dr.
Yeah. No, thank you. Thank you, Dr. Oshima. So actually, if for this excellent discussion on rejection, but if you still have a couple of more cases, you're most welcome to continue.
Okay,
Yeah,
then
sure.
One more quick thing. So this is atypical rejection. So sorry, slide is faded. De novo autoimmune hepatitis. So some patients may develop autoimmune hepatitis type of hepatitis, and you can see many plasma cells here. And we used to call the de novo autoimmune hepatitis, but nowadays we consider this is also a typical form of rejection. Okay. Yeah, I think that's it. So,
Thanks a lot again, Dr. Oshima, for this excellent discussion on transplant pathology. So let me see if there is any question that anyone might have. I have a question too that I wanted to know, like, do you rely on any stain for acute cellular rejection, or any special stain or immunostain? Do you need any stain?
no, unfortunately, this is a generic diagnosis, but like C4D stain, so humoral rejection is quite rare in liver. I mean, more commonly seen in kidney. And whenever some unexplainable liver dysfunction, clinicians often ask C4D stain. And like 2016, so BAM criteria established like diagnostic criteria for C4D stain. So it's a controversial area, and there is, I don't have, still it's so not common, and it's difficult how to handle, but whenever unexplainable liver dysfunction, so I made a C4D. But in terms of acute cellular rejection, generally it's HLA diagnosis.
So yeah, thank you. So otherwise, like you will very rarely do C4D stain also, right? For humoral rejection.
Yeah, it's rare. So.
Okay. And among the different components that we discussed about acute cellular rejection, like presence of bile duct injury, venulitis, and portal inflammation, which criteria is more reliable for you? When do you have to see all the components when you say rejection, or one is more important than the other?
That's a very good question. And one thing is, so recurrent hepatitis C and rejection, because of histologic overlapping, it used to be extremely difficult. Mm-hmm. And because chronic hepatitis C recurrent also show very mild endotheliitis and portal inflammation all the time. And again, so whenever, if I call rejection and clinician use immunosuppressor, hepatitis C gets worse. So I used to be very conservative to call rejection. However, that's also changed drastically due to improvement of hepatitis C treatment. So that's why I think bile duct injury is very reliable, because endotheliitis could be seen in hepatitis C recurrent. So like endotheliitis could be, of course, both of them could be subjective. So I mean, both of them are needed. However, bile duct injury, I want to say.
And what about the eosinophils? Is there any specific importance that you play on the presence or absence of eosinophils in the portal inflammation?
Actually, yeah, eosinophil could be sometimes helpful, because as I say, mild acute cellular rejection, I mean, only lymphocytes, but moderate. So like rejection, we often see eosinophils. So it's not a diagnostic criteria, but like soft, like minor.
Right.
Yeah. But again, so because hepatitis C becomes treatable disease, so to call acute rejection used to be more, I didn't want to call acute cellular rejection easily, because of generally surgeons get worried, and they tend to treat acute cellular rejection aggressively, use a lot of drug, and often hepatitis C got worse. And all time, so fibrosing cholestatic hepatitis C, we don't see anymore. And like even 5-6 years ago, so recurrent hepatitis C used to kill the patient. But now treatment gets so better. So it's just one of unbelievable good change in transplant pathology. So I can call more acute cellular rejection with like
more comfortable.
more comfortable because they can treat rejection as well as without worsening hepatitis C.
And another thing, like what about the viral stains? So do you do like CMV stain regularly when you evaluate for acute cellular rejection, or only when you suspect?
I do only at the time suspicion. However, probably because nowadays, so it's not so common. Mm-hmm. But still, I think we should always keep it our mind. So that's a good point. Thank you. Yeah.
Okay. So thank you so much again. Now as you said that hepatitis C is good, like they are having good treatment for hepatitis C, and the transplant scenario is changing. So in adult patients, so what do you think the future, like what would be the more common causes of transplant and for liver transplant now that hep C will be easily treated?
Yeah, that's why it seems to be alcohol.
Alcohol is what it is.
Yeah,
I see.
because hepatitis C, so we don't get liver biopsy anymore for
Right.
hepatitis C grading and staging. And also another big change is donor.
Mhm.
So hepatitis C donor, we used to use it, but it's given to only hepatitis C positive patient.
Mhm.
And long outcome was not so good before. However, because of good treatment, so donor liver, so hepatitis C positive patient will become donor. And nowadays, my surprise is even some moderate fibrosis donor can be used
Right.
because surgeons consider it's treatable. So it's a huge practice change in even last 2-3 years.
Oh, that's interesting. So, what is your experience about change? You have been practicing liver pathology for quite some time. What's your experience in change in criteria for choosing donor? So, do we have very specific criteria, or the criteria keep changing, depending on an institute or something like that?
Also, I've worked with several different clinician group.
Right.
So clinicians sometimes make a difference. So some group are more aggressive than
Right.
others.
Okay.
So some group use little more aggressive treatment,
Right.
using offer
Right.
transplant
Right.
more risky patients, or use more donor with little more risky patients. So ultimately, so our job, so provide information. So
Mhm.
even stenosis is 50%, 60%, but otherwise, donor is young and die from trauma, and other conditions are good. So they may still use it. So these factors, it's hard to predict for us. So our job is provide accurate information, and the rest clinician would make a decision. And I practice in the Midwest and East Coast. To me,
Mhm.
so offering a transplant to alcoholic patient who drank even a month ago, it was unbelievable. However, outcome seems to be pretty good, and I also know that this patient generally cannot wait for 6 months. These people are dying if they are not offered transplant. So I think it would be a great hope for some patients, carefully selected patients. So it gives additional hope for life,
Right.
and it's a great thing. However, so pathologists, we really cannot see entire clinical picture. So as long as we can provide accurate information, so clinician can decide. And also our pathologists, so that's our task for clinician.
Right. Thank you again, Dr. Oshima. So you would be very happy to know that you had viewers from so many different countries, including your home country, Japan. Someone said hello from Kanagawa. I think that city you must be knowing. And there are viewers from Taiwan, of course, USA, India, Nepal, Syria, so Romania, Ukraine. So you had a lot of viewers. And thanks to the viewers for tuning in. And as always, so you can tune into our lectures, upcoming lectures, and you can tune into our YouTube channel and also our website, pathologycast.com. So thanks again, Dr. Oshima, for your excellent discussion and for the educative talk for us. Thank you so much.